breast cancer, well, it lacks a histologic and molecular marker, we all know that. And so it is a clinical diagnosis, and the clinical criteria hasn't changed since 1978. That's 40 years ago, and Lucas and colleagues actually listed these 8 parameters of clinical diagnosis of IBC. They're exactly what we use today, 40 years later. And so what's the problem? The problem is that there's variations in clinical presentation, and now that there's increased awareness of IBC among the population and healthcare providers, people are coming to the attention of healthcare providers at an earlier stage, an earlier time, and so their clinical presentation is not as extensive as it was in 1978. So this is our challenge. So I want to briefly discuss a couple concepts. One concept is, can we actually, instead of looking at a list of clinical criteria and you have to check off all of them, can we actually use a few criteria for diagnosis and use it sort of as multiple categories specifically to diagnose IBC? And a great example of this is by Kelly Hirko, who actually has a poster here today. And what she did was she looked at standard criteria for the diagnosis of IBC using the AJCC criteria of T4D, and I'll talk a little bit about that later, and breast enlargement, often without a mass. That's the SEER criteria for IBC. And then she designed a second, more diffuse clinical criteria for IBC where people can have either 2 of the 3 features of IBC, erythema, edema, etc., or code orange only. And she investigated 915 patients who were seen at an NCI-designated cancer center in Michigan. When one classified these patients using the SEER data, which is quite restrictive, there was an incidence of 2.1% of IBC patients among the 915 patients seen. When one used this sort of multifactorial diagnosis for IBC, then 6% increase incidence in diagnosis. Now that doesn't mean that these people were erroneously diagnosed. It's just that these people, the 6% of the people, would not have been classified as having IBC even though they did. And so this is a great example of using that kind of concept to modify the diagnosis of IBC. This is also a really interesting study from Paris, the University Hospital in Paris, published in 2017. So this was a clinic where 76 patients with inflammatory breast changes were evaluated. And what they did was they looked at several criteria during the evaluation, clinical criteria, which is on the left, and then they found that among these 76 patients, 50% of them had breast cancer that was not inflammatory breast cancer, 22% of them had inflammatory breast cancer, and 28% of them had an infection. And what was interesting to point out was there was really a difference in separating infection or a malignant non-IBC from IBC when breast pain was used as a criteria, skin thickening was used as a criteria, and specifically induration and tenderness, or lymph node involvement. So those were really the 3 criteria that separated these 3 groups in the clinic. So important criteria for this diagnosis. Another important criteria for the diagnosis, again, that we don't have as our standard diagnostic criteria, and that has to do with the rapid onset of these signs and symptoms. So these are data from the Dana-Farber, where 98% of the patients presented with an acute onset of these signs and symptoms within 6 months, but actually 70% presented within a 4-month interval with these signs and symptoms of IBC. So the UK focus group actually published their recommendations for the criteria for diagnosing this disease, and they focused on this rapid onset of signs and symptoms of erythema or code orange. Again, maybe 2 focusing clinical characteristics with this maximum symptomatic duration of 6 months. So again, keeping in mind certain criteria that we can use, not all for one person, but we can use amongst the category for diagnosing IBC, one being onset within 6 months of symptoms. So now what about this AJCC definition of IBC, and that's what we use in the United States. So the AJCC definition of IBC is a clinical and pathologic criteria. The 7th edition, which is what we use as clinicians all the time, really only has clinical definition of IBC. And it's specific. You have diffuse erythema and edema involving a third or more of the skin of the breast, then you can be classified as having T4D, a diagnosis. If you have less than a third of the breast involved with edema or erythema, you are no longer classified as T4D, you have a T4B diagnosis. And so, for some reason, this distinction is missing from the 8th edition, but the 8th edition adds a pathologic criteria, and that has to do with tumor grade. So most, if not all, of inflammatory breast cancers are more poorly differentiated on the right, grade 2, grade 3. There are some rare that are well differentiated, but those are mostly the locally advanced. So again, trying to differentiate IBC from locally advanced disease. Maybe tumor grade may be something that we need to think about in adding to our diagnostic criteria of IBC, rather than a specific amount of breast that has to be involved with these signs and symptoms. So you're going to hear more about the pathologic correlates of IBC later, but just briefly, we'll talk about the two main characteristics, clinical characteristics of IBC, and that is erythema and edema. So we've got rapid onset, we've got possibly tumor grade, now we've got erythema and edema. And the erythema, of course, is due to dilated capillaries, usually lymphatics. 70% of the time, they contain tumor emboli, which is mostly in the capillary and particular dermis of the skin. But we all know presence of dermal lymphatic involvement in the skin is not sufficient for the diagnosis of inflammatory breast cancer. And in fact, this erythema is functional, so it can come and go, which we all know because we talk to our patients. And so, again, we have to really keep in mind that the criteria for erythema has to be very specific or nebulous when we talk about the diagnosis of IBC. The edema part is more difficult because this is a great example where you can see the edema, you can see the fluid trapped in these lymphatics, but pathologically, it's very difficult to discriminate edema in lymphatics from tissue processing artifact or loose connective tissue. So that's more inflammatory breast cancer from a pathologic standpoint in terms of skin involvement. In terms of locally advanced disease, diffuse skin thickening and dermal lymphatic involvement isn't really consistent with locally advanced non-inflammatory breast cancer. The skin involvement in locally advanced breast cancer is often ulceration, satellite cutaneous nodules, and then you have inflammatory signs due to necrosis or stasis. So we may be able to involve some pathologic criteria in the diagnosis of IBC. The other, of course, challenge with inflammatory breast cancer is that you often have this diffuse peritumoral lymphatic invasion within the breast tissue itself, which you can see here, and it can be highlighted. This tumor and lymphatic vessels can be highlighted by CD34 IHC. So very clearly, you see tumor emboli in lymphatics in the breast, but no tumor in the stroma. So it turns out that, yeah, you can also have this peritumoral lymphatic invasion in locally advanced breast cancer, but the tumor involves the stroma. So that again is something that differentiates IBC from locally advanced IBC, and we may be able to add that to our diagnostic criteria. But I think what's really important, and this is what Massimo was alluding to this morning, we really need to use some type of a biomarker to distinguish IBC from locally advanced breast cancer. And there are several that we can use, not 100%, but we can also incorporate some of these into our diagnostic criteria, such as E-cadherin overexpression, ROC overexpression, decreased Wnt3 expression, high levels of activated STAT3 or EGFR. So there are some biomarkers that we even know today that we might be able to add into our diagnostic criteria for IBC. This is definitely an avenue for research. Well, what about radiologic criteria? Right now, there's no established data to support specific radiologic findings with IBC, and yet we all know clinically that imaging really plays a specific role and a distinctive role in the diagnosis of this disease. In terms of just mammography, this will, my pointer will work, I hope. Maybe, yes. Okay, so in terms of mammography, you see skin thickening in about 90% of mammograms with IBC. You see trabecular thickening and increased breast density. But what you see less often with IBC and more often with locally advanced breast cancer is a more isolated finding. Intramammary mass, architectural distortion with focal asymmetric density, not uniform density, and microcalcifications localized in that area. So mammography may play a part in terms of distinguishing locally advanced breast cancer from IBC. Ultrasound, of course, also helps because of the skin thickening. Again, diffuse skin thickening, not what we see in locally advanced breast cancer, and high vascularity, which we can pick up by ultrasound. We see the vascularity in IBC. But clearly, breast MRI is the best imaging for inflammatory breast cancer. It demonstrates the extent of disease in the affected breast as well as the contralateral breast. We all know that inflammatory breast cancer often involves the contralateral breast more so than locally advanced breast cancer. We see non-mass-like enhancement, which is usually very extensive in the breast, and not unifocal, which is what we see with locally advanced breast cancer. You see extensive nodal involvement in intramammary lymph nodes, subpectoral lymph nodes, all levels of the axillary lymph nodes. And of course, skin thickening, which you can see here, enhancement throughout the breast, and then you can see diffuse pectoral, parenchymal and chest wall edema with MRI. So MRI really can differentiate locally advanced breast cancer from IBC, and yet it's not part of the criteria yet for diagnosis, and we can consider that. So what's the impact of not diagnosing IBC? We have immediate effects. Immediate effects affects patient care. Patients won't be aware of their true diagnosis. They will be given inaccurate information about their prognosis based upon lack of evidence-based information, because we don't have evidence-based information on these clinical trials for IBC yet. And they won't receive optimal treatment. Now, yes, they'll receive preoperative therapy, but they may go on to breast conservation. They may go on to immediate reconstruction and skin-sparing mastectomies. Their post-mastectomy radiation may not be enhanced with a bolus. So it really will impact upon their care if they are not diagnosed with IBC. What about delayed effects? Delayed effects have to do with us, that we will make inaccurate policies for standard therapies for IBC, which will be based on clinical trials that have a small number of patients with IBC, and they're all classified as locally advanced breast cancer. And in addition, we will not only lose information about the biology of inflammatory breast cancer in terms of tumor biology, but we'll lose information about non-inflammatory breast cancer too, because we'll be grouping all of these subtypes together. And so everyone loses if we don't make the right diagnosis of IBC. All right, so now we're going to turn to the second part of this talk, from the diagnostic challenges to something to really think about, and that has to do with maybe in inflammatory breast cancer we can have this concept of limited metastatic involvement versus extensive metastatic involvement, and we can change the treatment options between those two.